In the studio right now, this hour, we expect to have Dr. Brian Lishenga, the chairperson, Rural and Urban Private Hospitals Association of Kenya, RUPHA, who will be discussing matters to do with payment disbursement and financial health of SHA provider. Now, a 2024 survey, we shall be going towards that survey that has been released with regard to how SHA is being implemented in the country. That will be coming a little bit later. Now, City, this past hour, we've just from having a discussion with Makueni Senator Dan Mazo on matters 2027 elections, where we are politically, and a lot of those who are listening, Kenyans pretty much have had a lot to say. City, if you could just look at what they are saying there, and let's just read what it is they are saying. And one is just, you even had that concern. Abduction is not arrest. You know, It is a matter that we've been dealing with here the entire morning, and as well that arrest by abduction. What law is the practicing or quoting? Just matters to do with that. That is Owen Kariuki and Robert Aduda as well. Ruto will be accountable for all these things. And as well as only in Kenya, where you define arrest by a police getting you in a car, not by what law you broke, yet the arresting police will never come to court to say why they arrested you. That is Mato Makandets. And Paul MJ here says, Dan Manzo is a great lawyer and senator from Makueni. However, hapo kwa abductions, being a form of arrest, can never be allowed to go unchallenged. Abductions are a crime perpetuated by state persons. Unemployment is surely more than 12% if you consider citizens of legal age that should be productive. City. Yeah, that is a Tumikia Kenya, and Manzo should define what an arrest is as well. And we talk about what is Dennis Aseto is my name, and there it is. They know they will be removed. Is that why IEBC is yet to be reconstituted? City, it is a concern that even as we speak right now, elections is just 2 years away. 2 years, City. See,
the question that hasn't been answered, and I immediately answered as far as I'm concerned to my satisfaction, is what is IEBC? Is it the commission?
Is it the secretariat?
Yes. And what is it? We understand what the secretariat does, but are we saying that in the absence of the commission, that the secretariat cannot do certain things?
Even as we speak right now, even the senator alluded to it, that the young people should go and register, because
which means you can't register.
You can't register.
The commission doesn't register voters. It's a secretariat. That's what it is. They are the operational arm. They're the ones who get these things done. And registering people as voters does not require a commission, does it?
Yes, does not.
So there are many questions that keep arising, and we keep saying things that, well, I say things that sometimes I don't even understand myself. And perhaps, again, like with most things, we will look for somebody who understands these things better than we do. And they can come and shed light on this. Yes.
Yeah.
But on the subject of what it is that we do, sometimes I feel that politicians should actually stop talking and explaining to us things that we all understand and see. Why? It's because they seem to be telling us what we know, and we seem to be going around in circles. And everyone talks, and at the end of the day, they go around and blame the president. And yet, the government, as we know it, is parliament, executive, judiciary. It's not even complicated. Yes. So, if we are to apportion blame, let the president and the executive have theirs apportioned. Let parliament have theirs apportioned. Let the judiciary have theirs apportioned. Because if the check and balance role that the other two arms of government are supposed to have in the executive, you're failing a president. You're complaining and blaming a presidency for doing what suits them, when it is your job to ensure that that doesn't happen. How?
Yeah. Because even the earlier conversation you're having with Senator Kiom Tata is delinking treasury from the presidency, and that needs an act of parliament to be there to do that.
Here's the thing. This is what I'm trying to say. The genesis of the financial crisis we are seeing today could be seen in the design, because the primary healthcare fund is entirely funded by Parliament. That is what the law says. The Parliament will appropriate money every year in the budget to fund level 2 and 3. So essentially, our hands are tied there. And then now your contributions, the ones Kenyans have been saying, hii pesa inaenda wapi, this 2.75%, that is going to the SHIF fund, which now is operational at level 4, 5, and 6. What we know, even from the history of NHIF, and this is why we are warning the government that you are falling into the same trap that collapsed NHIF. What we know from the history was that contributors, Kenyans, you and I, people who get chopped off on their pay slips or they make voluntary contributions, were quite, forget the voluntary ones, especially pay slip workers, were quite consistent in making contributions because what would you do?
You don't have an option.
So they just chop. They deducted your pay as you earn and every other thing.
Yes.
They chopped off that one also.
It gets chopped off, and employers were fined reasonably high amounts of money for failing to remit NHIF in time. So that sector was very consistent in paying. Now, people ask, why did NHIF fail? NHIF was failing because government agencies, ministries, departments, when they chop off the money from their employees' salaries, they are under no duress to remit. So you take a look at these parastatals, these ministries, they are sending the employees pay slips saying, tumekata, payee, what. And even KRA has the same issues with them because income tax, a lot of them didn't remit. Pensions have never been remitted for many years, and so was NHIF. So now, we are now back in that situation today because, one, Parliament appropriated a measly 4 billion shillings for primary health care for this financial year. A measly 4 billion shillings. And when we protested, we were told, you are putting the cart before the horse or the donkey. We don't know how many people have registered, so you wait. When we see how many people are registered, we'll go to Parliament and ask Parliament to give us more money. Of course, that is not going to work that way. Now, we now have a financial crisis at the lower level where 75% of Kenyans seek care. So your level 2 and 3s are the ones who serve everyone. And they are the same ones.
But the data as to who it is who goes to level 1 to 3 exists.
Yes, the numbers exist. And
so you know exactly what to expect.
Yes, exactly.
So that logic that you just mentioned, they were saying that wait for people to register, that doesn't...
It flies in the face of the data.
Yes,
it does. It looked like a convenient way to not make a commitment.
Yes.
So where are we today? The situation where we surveyed hospitals just to find out since 1st of October, this quarter, to end of December, how have you been doing financially now that we are fully in SHA? And what we found out is that for the hospitals which are contracted, 58% of them told us they have not received even a single payment, even one. So this flies in the face also of the statements, the public statements that are being, you have seen a lot of them, we've paid 7 billion, we paid 9 billion, we paid 12 billion.
Who was it paid to?
It's a question because, you see, 12 billion is serious money.
My friend, it's a lot of money.
If you pour that money into a group of just 5,000 hospitals, you can just do simple division if everybody was to get equally. It's a lot of money.
Yeah.
So the question then is it PR? Is it public relations? Because we have no visibility. And part of the things we are trying to achieve through asking providers is we should have payment transparency at SHA. Remember, part of the reason why they said NHIF was wrong, they said there was corruption. NHIF had corruption. There were cartels which were eating money. What we said about the cartels is, surely you have the data. You know, if you are paying a hospital, your auditors have a list of the hospitals you have paid. Publish. Make it public. We will if once you publish 100 names, you don't even have to write to us to write the figures you've paid, because people might say you're making our finances public. Just say we've paid these guys. The same way when public procurement tenders are done and people are awarded and paid, you find them on the website of the Public Procurement Authority. Say just publish the names of the people you've paid, cross-reference those names against the database at KMPDC. Because KMPDC maintains a register of all validly licensed and registered open facilities. So if you say you've paid Brian Lishenga's hospital, KMPDC can quickly tell you that's a fake hospital if it doesn't exist.
It doesn't exist, yes.
You know, so what we are trying to say about this is let's not have public statements saying, hey, since November, we've paid 7.3 billion. And then when you ask the hospitals, have you gotten money? Close to 60% tell, we are not seeing it. If you ask Kenyans, are you being asked to pay out of pocket when you go to hospital? Kenyans are telling you,
Yes.
in fact, today morning, I have been asked to pay. And when you break down the data granular, what do you find? You find, for instance, 67% of primary care hospitals, the level 2s and 3s are telling you, they are saying ata peni hatujaona. And then and you know, this is why, and I've been getting a lot of calls from ministry people saying you guys are fighting reforms. We are not fighting reforms. We have always said as hospitals, it is in our best interest for SHA to work and in the interest of Kenyans, because if it doesn't work, what do we have?
Yeah.
Now, when you look at it, you see 67% haven't been paid. But when you break it down, you even see there's a difference between private hospitals and faith-based hospitals. So the private hospitals, 81% of level 2s and level 3s
They're even worse off.
are worse off. The faith-based organizations are not really any better because I think about 58% of them also say they haven't been paid. Now, this is the pushback we are getting. After we publish this data, which by they also include Ministry of Health facility, even public facilities also participated in the survey, and they also said they are suffering. When we publish this data, now the discussion is no longer about whether we have paid you guys or not. Now they want to see what was your sampling methodology. You know, now they are, in fact, I am feeling like very soon we might be summoned to appear before an organization like Kenya Bureau of Statistics or somebody to say, okay, can you explain? We have pushed back, told them, it's not about RUPHA or whoever publishing a survey. You as SHA have the data of who you are paying. The CEO of SHA wrote a memo 2 days ago and said, I have paid 5,000 hospitals.
Which hospitals is the question? 5,000
hospitals. Now, we as hospitals know that the total number of contracted hospitals is 3,994. So, you know, that kind of stuff is very dangerous, because we will quickly ask him, who are these other 1,000 who are not contracted that you have paid?
Daktari, we're talking about matters to do with healthcare, and here's a question of SHA. We have paid over 5,000 hospitals, and according to you, you have 3,900 hospitals. The extra 1,000 nikina nani. But let's talk about healthcare and how it's being paid and how this is affecting access to healthcare for Kenyans, because you have paid your dues, you have been deducted from your salary. You go to hospital and you're told you need to pay from pocket. I don't have that money. Just how dire is the situation for Kenyans to access healthcare in these hospitals?
Okay, so we had one of the survey questions we asked was a simple question. We asked hospitals, straightforward question, are you in financial distress? It was a yes or no, no other choices.
I'd just like to backtrack a little bit.
Yes,
so that when you give that information, it makes sense. Who are which hospitals or which groupings of hospitals did you collaborate with?
So the survey was conducted between the 24th and the 31st of November.
Yes.
December rather. And we sent out the survey to about 1,500 hospitals, which are within covered by 4 associations. That is the Rural and Urban Private Hospital Association, RUPHA, Kenya Association of Private Hospitals, the Christian Health Association of Kenya, CHAK, which is the one that oversees your PCAs, Akina Kijabe, and then the Kenya Conference of Catholic Bishops Secretariat, which is for the Catholic hospitals. We sent out to all these 5 associations because we decided to collaborate on this particular one on payments. So what we did get out of the 1,500 possible respondents, we received 272 responses, which is sufficient for that population. In terms of, it's a very good sample size. It's more than it's somewhere close to 15 to 20%, 15%. So we then analyze that data. So we know that 20% thereabout of the respondents were faith-based organizations.
Okay.
And then about 3% were Ministry of Health, which we generally excluded from the rest of the report, except for a few insights, because we felt the sample size was too small. It was about 10 facilities. And then we had 77% was private sector. Now, the reason we felt fairly confident about this data was that it actually more or less aligns with what we have nationally in terms of the distribution of facilities, with a very big skew towards private sector investment.
Yes.
And also, we also felt like there was an overrepresentation of faith-based, because the faith-based hospitals which are registered in Kenya are about 350 only. So if you can get even 50 of them responding, it's a very big response from that group. And then we broke down the data to see how many are level 2s, how many are level 3s, 4, 5, 6, etc. And also what we found out from that data is 65% of the private hospitals were what we call primary, level 2 and 3.
Okay.
And then about 53% of faith-based were level 2 and 3. About 32% of respondents on both sides, both faith-based and private, were level 4s. Now, the level 5 and 6 were a very small number on the private sector. It's just 3% on the private sector, which is consistent with the national data. On the FBO side, the level 5 and 6 were 13%, which is consistent also with their representation there, because they have invested heavily in our PCA, Chogoria, Kikuyu, AIC, Kijabe. They have a bit of a good number of level 5s and 6, level 5s especially in this country are faith-based organizations. So when we look at that sample, it was fairly consistent with what is there in the register. Now, out of these 272 facilities, we then cleaned up the data a little bit, because we noticed about 7 facilities had answered twice. So we had duplicates. So we removed them. And then we removed also some facilities which had told us, because one of the questions earlier was, are you contracted by SHA? So we had about 12 facilities which said no, we had not signed contract by SHA. So we removed them. We ended up with 243 unique facilities that we can sample. We looked at them. Now, that is the sample size we carried forward, and we started disaggregating it, saying, okay, let's deal, for every question we were doing, we say, how are primary care facilities doing and how are tertiary level facilities doing. So even on the financial distress question, we got everybody to answer. It was a mandatory question. But then when we did the analysis, we said, okay, let's ask ourselves, are primary facilities doing worse than tertiary facilities?
Who's doing worse?
And you do, of course, primary facilities are doing much more worse. And for me, and this is what I think that our colleagues at the ministry and at the presidential advisor team, what they should be doing is not saying sample design, etc. Because my background is actually academic research. Yeah. So we can go into that discussion and never finish, But what they should be saying is that what is it out of this survey? And we've done, like the SHA transition surveys where we were monitoring the SHA transition, we have done 6 of them. We are actually going to send out another SHA transition survey in this month of January. We've done 6 of them. They have the reports, and they should be asking ourselves, why does the sample, why does this data say level 2s and 3 are suffering? What is it that we got wrong in our design? Or what is it that we are missing? Do you know what? The answers are just right before them. Let me give you a simple answer. For example, primary care facilities only exist on something called capitation payment. Capitation payment, which even Kenyans don't understand, is a fairly complex topic. But what it is in a basic term, they say, how many Kenyans live in a place X? Okay, 100,000. So if there are 100,000, how many of them have contributed to SHA? Okay, 40,000. So they are supposed to take 40,000 contributors to SHA and allocate each one of them, 900 shillings per year in the budget, and then pay those facilities there to take care of these people. Now, as I started by saying, if you follow that, the amount of money we need to offer primary care in Kenya is 45 billion. Okay?
45 billion.
Yes, 45 billion. Because you see, do just back of the envelope mathematics. 900 bob per Kenyan. Say we are 50 million Kenyans. We need 45 billion. Now,
what is the amount then that will be allocated to each individual?
900 shillings per year.
It brings us to 45 billion.
Yes, brings us to 45 billion. Now, let's come to where we are. I heard the president say, Juicy, recently, that we have now registered 17 million people in SHA. So let's assume that's what we are dealing with. If we are dealing with 17 million Kenyans in SHA registered as at today, first week of January, it's simple envelope math. 17 million times 900 bob. We need roughly about 17 million times 900 bob. We need roughly about 17B to provide care for Kenyans up to December.
Yeah.
That's what we need. Now, does SHA have that money? I will tell you plain that they don't have the money. They don't have the money because why? The primary care fund is a parliamentary appropriation. Parliament closed that story with the last finance bill, isn't it? They appropriated 4 billion. So for us, unless it's a supplementary, there's no other way to reach 17 billion to provide care for these 17 million Kenyans. Now, so as long, and this is the alarm we are raising, as long as that is the scenario, level 2 and level 3 facilities in this country will keep on having financial distress, one. But even what should even worry them more is the fact that an ordinary Kenyan who has been promised that you will be walking to a facility and walking out without paying, that is not going to be their experience. Their experience will be, because the facility has to pay, the nurse has to keep the lights on, they will pay out of pocket. When we surveyed in the last survey we did on SHA transition in December, which was not a payment survey, when we asked providers what is the public perception on SHA, the number one problem the public was saying was out-of-pocket payment. Out-of-pocket payment. So we went further and asked providers, how many of you are charging? And this is a very sensitive question. Imagine asking a provider to disclose that they are charging people out of pocket. But they were gracious enough and responded. And I even believe that data was more mild than it should have been. About 60% of hospitals said every single patient who walks in has to pay. They have to pay. And we asked them, why are Kenyans paying? Why ask them to pay? And we found that there were multiple reasons. Of course, some of them are not registered by SHA. Some patients actually just were saying we don't want to register. Let me just pay cash and go. Others were technical issues because the way the system is designed now, you have to get a one-time PIN on your phone before the hospital can process you. You are there 3 hours later with a child with a fever. The PIN hasn't arrived. Of course, the mom will say, okay, kwani ni pesa ngapi? See, I just pay this, I go. I'm waiting for this PIN, is not coming. But deeper under that were hospitals saying, if I have nurses who are asking me to give them one of the wards walale hapo because landlord amefunga nyumba. There are hospitals who are telling us we send patients across the street to the chemist to pick drugs because we don't have the drugs, we don't have the supplies. And the reason why we don't have this is we don't have money. Now, the ministry people would argue that why are hospitals complaining at a SHA ijaanza that time. But they forget another elephant in the room. It is called NHIF arrears. Money that these hospitals were paid, were owed by NHIF over years. I mean, I know of a public hospital, let me say, mention his name, that is owed 1 billion shillings by the defunct NHIF since 2017. The only reason why that hospital is still running is because taxes pay the salaries of their workers. If it was a private sector hospital, that one we would have auctioned it. Yeah. Now, some people even thought that these hospitals, za makanisa, they get sadaka. Yeah. So maybe they are not under distress. Yeah, people argue like that our these faith-based hospitals, they are collecting tithe.
But even if that is the case, that is not the discussion.
It's a diversion.
Yes.
It's totally diversionary.
If you have a new system and you refer to what is often called teething problems, everything you've described, would it fall into the category of what we'd call teething problems of a new system?
Yeah, so it's a mix of things. One, there's teething problems, but others are, if I use Kiswahili, which is not my mdomo, others are mwiba wa kujidunga. So some of them are problems you could have predicted will happen.
Or maybe they were seen, because in designing something of this sort, and you already have a system that you can learn from, if this is what we're dealing with, and we had a system that we supposedly learn from, then did we learn anything from the previous system, which we said had problems? Because these problems seem to be more than the problems we had from
before
the previous system. And that's why I asked whether these are just teething problems, because they're thinking behind it, and when we look at what it is that they're saying, one could say, yes, it looks like it's a good thing. But now, the issue of it actually working, what we normally call implementation. I was reading the article that spoke of the survey that you did. And one of the things that was mentioned, that 40% of people who were surveyed, 40% claimed that they had actually received payments from the defunct NHIF. They received.
They got, yes, 40%.
40%. Now, when they say they got, do they mean they got everything they were owed, or they just got some money? Because
it's a very interesting question, City. So there was another question there about what percentage of your, if you have been paid, what percentage of your liabilities has been settled?
Yes.
And do you know what we got? The vast majority of them said less than 10%. Vast majority. And that figure was worse the lower you go. In other words, if you have a smaller hospital, you are more likely to receive less money than if you have a larger hospital.
So then it begs the question that we had asked earlier on, if the amounts that we were told had been disbursed, and if you were to do the maths, whatever it is that is spoken of by the administrations of these hospitals, does it amount to that?
Oh, you mean like by what is odd?
7 billion was given.
Yes.
When you talk, maybe you didn't ask the question, but I'm asking the question. This is a rhetorical question.
Yes.
Does the total amount of money that was received by hospitals, and they say categorically they received, would it amount to 7 billion?
No.
Okay,
No.
So let me backtrack again. What was the sum total of what was actually owed? What are hospitals claiming in total?
So your question is very interesting. One of the things that we as Kenyans have not properly demanded is in February last year, the then Cabinet Secretary Nahumicha gazetted a committee called the Transitional Committee,
Yes,
which was headed by one Jackson Kipkarwok. And it had quite eminent personalities in there, technical guys. To this day, as we are sitting here, which, by the way, they used public resources for over 6 months to go and audit NHIF liabilities, assets, employees, etc. That report to this day has never been made public. So one of the problems, and we have, as an association, we asked, we said, we are an interested party. We want to know, by the way, what did your experts find out? How much actually does NHIF have on its books as liabilities, assets? I mean, if you're going to and this is a very important question, because the NHIF did not have any money that was government money, if I might call it government money.
Yes.
All the money that was in NHIF was contributors' money. So this is money for people.
Yeah.
So it is truly not out of place for the people to ask,
excuse me,
excuse me, you have collected my money for God knows how many years, and where did you buy shamba? Who do you owe? So they didn't make this report public, and we even had to invoke the Access to Information Act and write to Jackson Kipkarwok and tell him, as citizens, we have a duty to know, now that you have used even our public money, to sit down and do what is it. But that being as it may, we do have people called whistleblowers. So whistleblowers sneaked the main part of the report, not the annexes. they sneaked, because I mean, whatever you say about Kenya, we still have a lot of Kenyans of goodwill out there. Many. Yes,
we would have collapsed a long time
ago. Yes. Even within these institutions, there are guys who just say, no, this is not right. We must get it is not right. So we saw the report, a sneak of that report, the main report. And what I have seen on those books is NHIF says that it owed providers 25 billion as at the beginning of August. But it also confesses in the report that there is 2.7 million in sorry, let me backtrack. Not 25 billion. They owe providers 15 billion verifiable. 15.7, just about there. Which means that if they log into their software, they can see these are claims which we owe. But then they said at the same time that there is 2.7 million claims, which they don't know their value.
Yeah.
And it is hanging somewhere.
Time.
Daktari.
Time.
Time is not on our side. Dr. Brian Lishenga, Chairperson, Rural and Urban Private Hospitals Association of Kenya, matters to do with SHA. This is a conversation that we will invite you again to discuss further, to know where our healthcare status is and if SHA at all is working.
This is the Situation Room, the only way to start your day.